Hello everyone, I am Dr. Abhijeet Singh, resident in Department of Radio Diagnosis, D.Y. Patil Medical College, Navi Mumbai, and I am presenting my paper on foreign body granulomas, finding answers to a slinking twist on cross-sectional studies. Foreign body granuloma is a tissue reaction for retained foreign bodies after skin penetrating traumas. Detection of retained foreign bodies can be extremely difficult when the patient presents for evaluation several months after or even years after the initial injury with non-specific symptoms and uncertain history of trauma. The radiological appearance of foreign body granuloma can be confusing and can even mimic a neoplasm. In our cases, plain radiographs could not reveal the existence of foreign bodies due to non-metallic or radiolucent nature of the foreign body. Magnetic resonance imaging showed foreign bodies as low intensities on both T1 and T2 weighted images, with the surrounding reactive tissue as low to iso intensities on T1 and high intensities on T2 weighted images. The peripheral areas of the lesion were strongly enhanced after gadolinium injection due to granulomatous tissue formation. The key to arriving at the correct diagnosis is to clarify appropriate history and to identify foreign bodies with the low signal intensities on T1 T2 weighted images, characteristic ring-like enhancement on contrast-enhanced MRI. Aims and objectives to get a better understanding of the foreign body granulomas via proven cases, the spectrum of clinical presentation, clinical examination, the cross-sectional study interpretations, differential diagnoses in such cases, and in turn providing clue to influencing the further management of the patient. We present three patients with foreign body granulomas mimicking soft tissue tumors with emphasis placed on their unique clinical and imaging features on CT and MRI. An 83-year-old female, which was referred to our department with history of pain in right ear associated with decreased hearing since 2 months. No history of any ear trauma, bleed, or discharge was given. Examination revealed fleshy mass, occluding the external auditory canal, which was non-tender, did not bleed on touch, and could be proved from posterior and inferior aspects. It was clinically suspected to a vascular malformation. Patient was advised on an HRCT temporal bone, which revealed a mixed soft tissue and fluid density area/lesion with areas of air fluid levels in the right external auditory canal with few areas of near calcific densities. Mild thickening of the tympanic membrane was seen, and no evidence of any adjacent bony erosion was seen. These are the images. In view of the above findings, considering the age demographics of the patient, possible radiological differentials include an infected keratin cyst, less likely a polyp, and a neoplastic etiology. Clinical and laboratory correlation with contrast study was advised for further characterization of lesion in view of the clinical suspicion of a vascular malformation, following which the MRI temporal bone with contrast study was done. These are the images. MRI temporal bone with contrast revealed an oval-shaped, well-defined area of ultrasignal intensity, appeared hyper-intense on T2 weighted, hypo-intense on T1 weighted images, and tiny T2 weighted hypo-intense intense focus, and surrounding T2 weighted hypo-intense rim, seen involving the inner aspect of the right external auditory canal, with evidence of adjacent perilesional T1 T2 weighted hyper-intense signal intensities and subtle area of restricted diffusion seen in the periphery of the lesion. On post-contrast study, mild peripheral enhancement was seen. On dynamic post-contrast study, there was no evidence of any early arterial enhancement. The radiological findings were likely suggestive of an infected granuloma in the right external auditory canal. The possibility of a foreign body granuloma was suggested. In view of no arterial enhancement on dynamic contrast study, possibility of a vascular malformation was ruled out. Intra-op findings confirmed the suspected foreign body granuloma as the tip of an in-ear earphone. 77-year-old male patient was referred to our department with a history of right nasal blockage and difficulty in breathing from right side of the nose for 2 months. No history of nasal trauma, bleed, or anosmia was present. On examination, a pale mass was seen in the right nasal cavity, which was non-tender and soft on probing. The mass could not be probed from all sides, with suspicious attachment to the inferior turbinate. Reduced fogging is seen on right side. Patient was advised a CECT PNS, which revealed a pedunculated overt soft tissue mass lesion with average attenuation of 32 to 38 HU is seen in the right nasal cavity with the stalk of the mass arising from the right ethmoid sinus and the bulk occupying the middle and inferior nasal meatus causing near total luminal compromise. On post-contrast study, there is minimal enhancement seen. Findings are most likely suggestive of a right ethmoidal polyp with extensions into the nasal cavity. MRI PNS was subsequently done with contrast study. It showed an expansile, well-defined multilobulated area of altered signal intensity, which appears hyperintense on T1, predominantly hypointense with dependent hyperintensities on T2 weighted sequence. In the mid portion of the right nasal cavity, it shows no restricted diffusion on diffusion weighted images. On post-contrast study, it showed minimal peripheral enhancement with evidence of an enhancing component in the anteroposterior aspect. The lesion is causing significant luminal compromise of the right nasal cavity and closely abutting the right nasal turbinate with inferior and lateral displacement of the right inferior turbinate with medial displacement of the nasal septum. It is seen abutting the inferomedial wall of the orbit with no obvious defect noted in the floor of the anterior cranial fossa or no intraorbital or intracranial extension seen. Findings most likely suggestive of benign etiology. Possible radiological differentials include nasal mucosal, cholesterol granuloma, polyp with high proteinaceous content. Intra findings confirmed the suspicion of a foreign body granuloma mimicking a soft tissue lesion. A 6-year-old male child was referred to our department with history of trauma, not associated with loss of consciousness and vomiting. There was history of right supraorbital swelling, which was gradually progressive in size. These are the images. Subvalial soft tissue swelling was seen in the right frontal region with few linear and nodular hyperdense areas noted within, suggestive of a foreign body granuloma. It showed peripheral enhancement on post-contrast scan and is seen causing scalloping of the outer cortex of the right frontal bone in supraorbital region. Intra-op findings confirmed a foreign body granuloma in form of an infected gravel. It is very difficult to suspect foreign body granuloma, particularly when there is no previous history of trauma. In morphology of these lesions varies widely depending on the type of the material involved, the size of the foreign body, and the site of the trauma. When the history of the previous trauma is not obtained and the foreign body inside the lesion is not recognized radiologically, foreign body granuloma is easily mistaken for a primary soft tissue neoplasm. The foreign body reaction is the primary reaction of a non-specific immune system in response to the implantation of the foreign bodies. Granulomas are not a simple chronic inflammatory reaction, but rather a characteristic aggregate of immune cells with a compact structure composed of macrophages, lymphocytes, plasma cells, fibrocytes, and angiogenesis, which participate in an organized process that aims to envelop the pathogen. The immune reaction created by these cells is capable of stimulating surrounding angiogenesis, recruiting additional immune cells and fibroblasts, enabling them to encapsulate the foreign body in a collagen matrix as an attempt to segregate or destroy it. This is the matrix or the algorithm for an approach to a foreign body suspicion. For foreign body evaluation, we recommend performing sequences with 3 to 4 mm section thickness and T1 weighted images and fluid sensitive imaging in 2 to 3 orthogonal planes and axial gradient echo sequence, isotropic volumetric fast spin echo T1 T2 weighted imaging without fat suppression and imaging performed after administration of contrast material in 2 orthogonal planes. A metallic artifact reduction sequence might help, although it is rarely needed. These are the references of the study. Thank you.